This is Baron Lonner. I'm a surgeon at NYU Hospital for Joint Diseases, presenting a surgical case of adolescent idiopathic scoliosis treated from a posterior approach with pedicle screws. This is an adolescent girl who has a large progressive thoracic idiopathic scoliosis. You can see that the lateral x-ray shows that there's a significant hypokyphosis or loss of hypokyphosis, which is typical of idiopathic curvatures. You can see the lumbar compensatory curvature is highly flexible, and this allows us to do a selective thoracic fusion in this case, the thoracic curvature being the structural curvature here and being more rigid. The approach to this is a posterior approach, again addressing the thoracic curvature. A subperiosteal dissection of the spine is performed, exposing the transverse processes and the facet joints and the midline ligamentous structures. The interspinous ligaments are removed with a Lexel rongeur as shown here. And then at each segment, facetectomies are performed, which have already been done, and now I'm performing Ponti osteotomies, in which the intersegmental resection of the ligamentum flavum and the superior articular facets are removed. This was described by Alberto Ponti originally for Scheuermann's kyphosis, for shortening procedure, and we do this to enhance correctability of the spine in the coronal, sagittal, and axial planes, but especially for the coronal correction and for allowing us to lengthen the posterior column. So by lengthening the posterior column, we can restore kyphosis. And between, as I do these osteotomies, we apply collagen thrombin combination for hemostasis. I'm now placing pedicle screws starting in the lumbar spine on the concave side. I use a high-speed burr to enter the introitus of the pedicle, and then I take a drill, a 2mm drill bit, which I have marked and calibrated for the length that I need. This is a fine technique that allows me to enter the pedicle continuously feeling the tip of the drill. I find this to be the safest approach rather than using a pedicle probe, although I do use the probe in certain circumstances at the upper end of the construct typically. We then introduce a palpating probe to ensure intact bony margins at the caudal, medial, cephalad, and lateral borders of the pedicle, as well as an intact floor. And doing this in combination with the drill allows us to have safe placement. This is a uniplanar screw, so it is mobile only in the cephalad caudad direction, which allows for some variability of placement of the screw, but is fixed in the medial lateral direction, allowing for a derotation maneuver to be performed without with the maximal efficiency. So at the proximal and distal ends of the construct, I use a polyaxial screw, mobile in all directions, and at the intermediate segments I use the uniplanar screws. Again, this enhances our ability to correct rotation. And so here, moving my way up the spine in a cephalad direction, placing screws segmentally at each level gives us maximal control of the curvature. And the key is to place these harmoniously so that the uniplanar screws line up in a harmonious fashion, because there is no variability that is afforded by a polyaxial screw. And you can see the mobility of the spine now after having performed the ligamentous structure remover, the interspinous ligaments, the supraspinous ligaments, the facet joints being facetectomized, and then Ponti osteotomies at 4 or 5 of the apical segments. And just I use again this technique of burring followed by the drill bit, and we use anatomic landmarks in the areas of Ponti osteotomies. I am able to use a Woodson probe, a dental probe, to palpate the pedicle if there's any question due to difficulty with anatomy. And you can see this is a fairly dry field, and the reason for that is we have controlled blood pressure. We, on exposure, use a mean arterial pressure of below 75 millimeters of mercury, and this allows for results in less blood loss on exposure. That and meticulous dissection, of course, is important. As we do the correction of the spine, we allow the mean arterial pressure to drift upwards towards 80 or 90 millimeters of mercury. This is in order to be protective to the spinal cord during correction. In addition, based on level 1 evidence, a study that we've performed comparing antifibrinolytics, tranexamic acid, and Amicar, aminocaproic acid, to normal pharmacological treatment, we found that blood loss is diminished in adolescent idiopathic scoliosis surgery with the use of the antifibrinolytics, in particular tranexamic acid, TXA. So we use that routinely now for these patients, and particularly for those that are more difficult. There are some situations, particularly here at the apex on the concave side of the scoliosis, where the pedicles are very narrowed and sclerotic, and that's due to the long-standing nature of this deformity, and the pedicles become dysplastic. So in some cases it may be difficult to enter the pedicle with either a drill or even with the probe, but here, because I was having some difficulty entering, I used the more rigid probe that is allowing me to get into the pedicle. And so then being very careful to use the calibrations and to get a good feel of that, and I gently rock the probe back and forth and have it. I can see that based on that maneuver I have a firm fixation into the pedicle and vertebral body. And then I'll introduce the feeler again, or the sounding probe. If there's any bleeding from the hole, we stem that with the use of the collagen thrombin combination. Again, with the placement of the screw, there's a torque that is transmitted to the spine, and that shows how strong the fixation is and how really powerful these screws are in allowing us to correct the spine, as opposed to hooks that were used in the earlier generations of segmental constructs. And as I drive the screw head down to the spine, you saw that my assistant uses a burr, high-speed burr, to burr down the transverse process, or the cortical, superficial cortical aspect of the transverse process, so that the head of the screw is not pushed medially, resulting in the tip of the screw coming out laterally. And I can adjust the heads again so that they're harmonious in their alignment and contour. And this will facilitate placement of the rod that we'll place shortly. So we'll continue with placement of the screws on the concave side of the spine. And here I'm using a dental probe, or a Woodson probe. Since I have an inner spinous opening by resection of the ligamentum flavum, I can easily palpate the pedicle, and that really allows me to define the cephalad, caudad, and medial aspects of the pedicle, guiding my probing of the pedicle. You can use a bipolar cautery to control any local bleeding of epidural venous structures. And we pack the wound with rolled sponges and really maintain hemostasis. After using a 2 millimeter drill, I then go to a 2.5 millimeter drill bit, and to increase that. We use both somatosensory evoked potential monitoring and transcranial motor evoked potential monitoring to assess spinal cord integrity, and the motor evoked potentials give us instantaneous feedback as to functioning of the spinal cord. It is particularly sensitive to blood pressure changes, but has been an important modality in our treatment of scoliosis patients. There can be false positives in the false negatives in the use of somatosensory evoked potentials, as these monitor the posterior sensory tracts, and the transcranial motor potentials allow us to monitor the anterior motor tracts of the spinal cord. And again, is a very sensitive modality, giving us instantaneous feedback within seconds if there were to be an event. And we find that if there's a bilateral diminishment, that is often a sign that blood pressure is low, or that the patient's hemoglobin may be low, and so we adjust pressure and hemoglobin and fluids based on that. Again, you can see here the harmonious alignment of the screws. Well, after we've placed both concave and convex screws, and I've already done that, we then do evoked EMG monitoring. We stimulate the center of each screw in order to test the threshold. As you increase the current, there is a reading distally at the lower extremities. So we take as a baseline 7 milliamps as indicating that there's an intact cortical bony margin around the screw. Here we check with fluoroscopy. So after I've placed the screws in a freehand technique, we check both on a PA and a lateral fluoro to ensure that the screws are in good position, and we can arc the fluoroscopic machine to assess the trajectory of the screw. Here I am cutting and then contouring the first rod, which is the concave rod. I use cobalt chrome, which has a greater strength and stiffness than titanium and then standard stainless steel. So this allows us to really hold correction, to obtain and then hold correction within rigid deformity. And the key is to over contour the concave rod to really pull the hypokyphosis into a more kyphotic configuration. We really want to match that to the patient's innate anatomy. Patients have a pelvic incidence that's innate to them, and that dials in lordosis. So we sort of look at pelvic incidence to give us a sense of what their lordosis and then secondarily what their kyphosis should look like. But we clearly want to reestablish kyphosis as part of our treatment. That enhances lung volumes or chest cavity volume, and we add a little bit of lordosis for the distal aspect here of the construct, because we do go into the lumbar spine here in this particular case, just at the proximal end of the lumbar spine. And I sight down the rod to ensure that I do not induce scoliosis into this. I want the rod to be perfectly straight in the coronal plane, and I again enhance kyphosis and put some lordosis in this. So, and that's really done on an individual basis for the patient and their innate anatomy. Here we are seating the rod proximally in the cephalad screws, placing set screws in, and then after I've seated the rod in the proximal screws, I'm able to cantilever the rod distally into the lower screws of the construct. And we place the rod in the coronal plane, taking advantage of the sagittal bends to enhance the ease, or to make it easier to insert. And we'll use the old-fashioned, quotes, old-fashioned hook holders to pull the spine to the rod. And this is really just allows us to straddle the pedicle screw and the rod, and it pulls the screw which is attached to the spine over to the rod. And we do this segment by segment. We use these clips which help us with reductions. These clips allow me to attach to the pedicle screws through a top-notch feature, and then I use a reduction screwdriver that introduces the set screw down and reduces or brings the spine to the rod and reduces the rod into the screw head.